Welcome back, everybody. Thanks for sticking around. I know it's a bit of a long night. I will try not to talk for 45 minutes. It's not a marathon, so you can talk the longest, but I'm going to go very quickly. As you know, my name is Stephen Andrew, and I am the Executive Director of Kidney Cancer Canada, Council of Canada. I'm also a patient. I was diagnosed in 2006. And I had a radical infarction in one of my kidneys. I had a partial part of my lung removed. I also went on sunitinib or Sutin for 4.5 years. And I also had some SPOT. So I tried everything. It's kind of like what do you call it? Potluck. Medical sites. But I'm not the only one. And today I have to tell you that I'm no evidence of disease, but I'm not the only one in the room that's no evidence of disease, although it is rare. Hands up those who are NED today. Look at that. That's exciting. That is really exciting. As we mentioned before, Mona Awad is with me. She's a communication, and also Andrew Welliger is our chair. Now, Andrew, very quickly, you've been on active surveillance because a lot of people get very upset about being on active surveillance. They think that the doctor's not doing anything. How long have you been on active surveillance, Andrew?
24, 25 years.
24, 25 years. So It is counterintuitive to walk around with a tumor in your body. I know that, but talk to us about it. And also, Christine Collins is our vice chair. And Christine, you've also experienced that too, right? You're getting an off there.
Yes, I have been on active surveillance.
How long?
9 years.
9 years. Terrific, exciting. The role of Kidney Cancer Canada is to improve the lives of those affected by kidney cancer across Canada by advocating for new access to treatments and promoting research and providing support, information, and education. That's our mission. We grasp that like you wouldn't believe. Hold on to it. And I'm very happy to report that you've been hearing about new drug cabozantinib, and as of this morning, it got its listing. So it means that provinces will be adopting cabozantinib across the country very, 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 very shortly. Kidney cancer in Canada, we talked about the numbers. 6,600 people will be diagnosed with kidney cancer in 2019. Sadly, 1,900 of those will pass. Our community is about 26,000 now, so that's a really good number. I think we're going to see a bit of a change with the new therapies that are coming on, because sunitinib, which was the standard of care for most cancer, was about 1 to 2% complete response, and now we're seeing anywhere up to about 11 to 18% response, depending on the type. So we have more drugs on the horizon. We know that Pembrolizumab, which is a new therapy that's just applied to come in Canada, that's doing extremely well. And I will tell you that Kidney Cancer Canada is there when they present a new drug, along with the clinicians. Kidney Cancer Canada files a submission recommending or supporting the new drug access, and then we advocate quite heavily for it. We believe in shared decision making. I think that as more drugs come along, as more therapies come along, it's going to be tougher to make a decision. And the clinicians alone obviously have questions, as you saw Dr. Ott talk about the fact that they're looking for biomarkers, they're not there. But gone are the days when the doctors stand around your bedside and say this to you: when we want your opinion, we'll give it to you. So what we say is, it's time to empower patients in the decision-making process. So how can we do that? Well, advocacy is the big issue, and that's what I'm here to talk to you about today. Advocacy is a huge thing. And what is advocacy? Well, I think the biggest tip that I could give you is that you need to be your best advocate. It's really, really important. Be an advocate. Don't be afraid to speak up. Don't be afraid to ask for a second opinion. Don't be afraid that when you leave Dr. Kapoor's office, or any office, and you have questions after the fact, don't be afraid to ask to get those questions filled. And I was talking to Dr. Kapoor about this about a week ago. What would you do? And he recommends making another appointment to go in and see him and get those answers. So it's a face-to-face response. We have a lot of patients that call into Kidney Cancer Canada, there were lots of questions that they didn't get answered at a time when they were sitting down with their clinician. So make sure that you definitely do that. Right, Dr. Kapoor?
I agree, and we have a lot of patients I was talking to, even in the, right here, is that they say,
We got a line?
Dr. Finelli is not, sorry, their doctor's not calling them back, right?
Yeah.
Inside voice. That their doctor's not calling them back. And so the problem is that we're busy during the day working, and so it's hard for us afterwards to answer all these questions by telephone, and we have to get home, otherwise our wives are yelling at us and so on, or our spouses are yelling at us. So the best time is to make a clinical appointment and say, listen, this is my list of questions. You got a captive audience again. He's right in front of you. He or she's right in front of you. You can ask those questions directly. So if your questions aren't being answered, you call the secretary, make an appointment to see that doctor. That way you have a face-to-face to answer any questions that you want.
Yeah, and what I recommend is start a journal and maybe have a list of questions, you know, as you're talking with your partner or the family, and you go, yeah, that's a good question. Write it down right away, because I can tell you as a patient myself walking down the hallway thinking, oh, another question. You know, I didn't ask that question. Write them down and go through them. You will get answers. And really it's advocating for yourself. Know your histology. That is really important. What is histology? Well, it's the size of your tumor. It is the makeup of the tumor. So you know what you're dealing with. So if anybody ever asks you, you can respond to it. We have some great sheets that are online called Understanding Your Kidney Cancer. And the doctors can fill them out, but you should know your histology. You should know what kind of cancer you have, what kind of subtype you have, the size of the tumor, because all this information is going to help you. Pace yourself with information. This is, again, important. Don't think the day, I mean, I kind of make a joke about it because I've been there. But, you know, they say, okay, Stephen, congratulations, you've got kidney cancer. And Wally will know about this because we've been in the same position. It's, congratulations, you've got kidney cancer, and congratulations, you're going to be doing a lot of homework over the next couple of weeks. And it freaks you out. You look for information. So pace yourself. You don't need to be an instant expert about kidney cancer. Ask for help. I think inherently don't like to ask for that, but how many people have come to you and said, since you were diagnosed, if there's anything I can do, let me know. And I think it's a great thing to do. So let people help you. They genuinely want to help. Whether it's, you know, when you come out the hospital, you know, that they've made a meal for you, or shovel your driveway, or just even, you know, pick up your mail in the morning, or whatever it is, ask for help. It's totally fine. People they want you to be well. They want you to succeed. And join our community. I cannot stress that enough. You will find so many resources on our website. You will find a Facebook page. You will find a private chat room. You will find abilities to communicate with other patients and clinicians. So join our community. If you're not, if you haven't signed up at Kidney Cancer Canada and you're getting our emails now, updates on what new treatments are available or meetings, you know, you need to do that. That is tremendous. It will give you information. The social media groups, I'll talk about the numbers a little bit later, but we have a number of them: Twitter, Instagram, I'm missing LinkedIn. They're all there. Please have a look at that. Connect with others. Connect with others on those social media programs. You can find that we have a new Facebook program, Facebook closed group that's come up, and it's grown, and people are chatting back and forth and giving suggestions, tips on how to deal with some of the side effects that are going on, and even just wishing people well. When we did it, we've been doing coffee chats across the country as well, and patients have been hooking up and taking each other to their appointments, and that's been pretty exciting because they build their own network, and I got to say, especially in Halifax, it's hello to Halifax. It's a really an amazing opportunity. Get free information from us. Tonight is free. Everything that we have listed on the front of our website, you just go to kidneycancercanada.ca. It says order free resources. It will be sent out to you within days. So please, use it, and also on the table, by the way, outside. Sorry for those of you online, that there's freebies on the table. Take it. That's all material that you can use. And if you need anything, any questions answered, let us know. And join a clinical trial. I've said for the longest time that the first question, I should have asked when I was, and we all do this, let's be honest. Hey Stephen, you got kidney cancer, and then you go, how long do I have? That's the first question that comes into your mind. And you've probably been there, you're probably still trying to work there. I think the first question you should ask is, what clinical trial could I go on that would extend my lines of therapy? We've been talking about 1, 2, 3 lines of therapy. We have a patient in the country that is now on their 8th line of therapy. What do you think of that, Dr. Kapoor?
That's fantastic.
Yeah, like 8 lines. Combination clinical trials, compassionate access, and also access to drugs that are on the provincial registry. So and that's another thing you can do. Go on to the social media groups and ask how you can extend your lines of therapy. All the doctors in the country now are freaking out that their patients now don't want 8 lines of therapy. And you know what I say? You can get 8 lines of therapy, more power to you. KidneyCancerCanada.ca. I should say KidneyCancerCanada.ca. I'll get to that in a minute. We've got more webinars coming up. Be aware we've done a webinar and we record them so that you can look at them. So we have a recording on the issue of exercise. It's counterintuitive, but when you're tired of fatigue, believe it or not, the evidence shows that if you can do any kind of exercise, it can invigorate you somewhat. Even walking, we were extremely tired the other day in Newfoundland, and Mom and I don't know what happened, we lost a couple of brain cells, decided that we were actually going to take a walk in St. John's to a store, and we should not have done that. By the time we get back, I had no fingers. But it was really, really cool. But more exercise is important. We are now developing education for patients that are on immunotherapy to help you through those decisions, to know when to go to the hospital, know when to call your oncologist, to explain the difference between immunotherapy and TKIs that will be coming up very shortly. And we have been advocating for 3 lines of therapy across the country so that every province will have 3 lines of therapy. We're in Prince Edward Island. Sorry, the Prime Minister help, but they do not have, the standard of care is ipi/nivo for intermediate to poor risk patients in everywhere except Prince Edward Island right now. Small province, but they need to do it. So we have been advocating, we were there trying to convince the minister that that was a good idea, and I am very optimistic we're going to see a change there. We're going to be doing patient orientation sessions. Join those again online. So if you can join it and get a refresher on what you need to know when you get kidney cancer. Regional meetings such as this one, we've been in Winnipeg, St. John's, Halifax, anywhere else we've been this year? And Vancouver earlier this year. Winnipeg, yeah. Winnipeg was exciting, let me tell you. Yeah. That's, I used to live there for 2.5 years, and to go back was interesting. And people understand me interesting. We were expanding our professional outreach, so we've really been connecting with clinicians such as Dr. Kapoor, Dr. Ott, Dr. Kommelsberger, Dr. Hang, and you'll see how they've really been participating, stepping up. And we have the Kidney Cancer Research Network in Canada, which is important, and the Medical Advisory Board. So nothing you find on our website is us making it up. We produce it, and then it is vetted by the Medical Advisory Boards. And Dr. Kapoor gets stacks of information sent his way. Even a tweet on something medical, we will not put it out unless our Medical Advisory Board has had a look at it, because the context of what is put out sometimes on the internet in a tweet needs to be vetted so that you know the context within the Canadian environment. And as Dr. Kapoor has noted, that there is a strong difference between what is there in the United States or Europe and in Canada. So that is very, very important. And we attend conferences around North America and also the International Kidney Cancer Coalition. We are an affiliate of that, and Andrew Waller and myself have been for the past couple of years. And then we liaise with other patient groups to find out what's important, what we should know, how we can deal with some of the sequencing challenges that are out there, not just in Canada, but globally, to pick up some good ideas and hope that we can raise awareness and change. Our Move to Beat Cancer fundraiser that we have, really to get people moving, is in September, and we are working on promotion of clinical trials, and we'll talk about that in just a minute. Okay, engagement. This is really important. This is a sign more people are getting engaged. In 2018, Kidney Cancer Canada, through its various social media channels, had 1 million impressions. I can tell you that we know we are going higher because this year, so far this year, our social media impressions are 168,880 above last year, and that is that's incredible. And this is what we can use when we are advocating for access to treatments, when we are advocating for support for doctors and clinicians. We can use these channels for influence. So it's really, really important. If you see a tweet from us, please retweet it. We really appreciate it. Or not just like the post. Likes are good, and we all like to be liked. But if you share it, our influence grows, and that's really, really important for every patient in Canada. Patients and caregivers tell us at the time of disease, and this is from a survey we did in 2015, that they recall the doctor telling them the specifics of the disease, 85%. They gave general information about the disease, 82%, prognosis, 73%, and then different treatment options, 61%, where to get information and support, 36%, and costs and access to treatment, 21%. Now, the board at Kidney Cancer Canada and the staff, we looked at this, and we looked at these three issues, and we were concerned because if patients only remember or perhaps are not given different treatment options, and so you basically, 6 out of 10, 4 out of 10 are not getting the information they need. And where to get information and support is a real big thing. So I'm sure you've all been looking around. So basically you've got 4 in 10 are only getting the information or reporting that. And cost and access to treatment is 21%. So 2 out of 10 patients were only getting details about access to treatment. So we also looked at the barriers to care and the supportive needs. And they were saying that they really would want to feel, overwhelmingly 68%, they want to feel like their healthcare team is managing their health together with them, and that they're getting the best medical care. And if you look at this other number here, which information provided in a way that they understand, 53%. We looked at that as a board, and our organization, we really want to work on that because that's only half of them are getting it in a way that it should be there. So we also asked, where did you get your information? Where are you going for your information? Most people say that they're going to their oncologist and urologist, 67%. Then in 2015, they were going to Kidney Cancer Canada at 55% and a family doctor at 50%. So we really wanted to strengthen that and give patients more information and help them with their advocacy, with their own advocacy. And that means to be informed. 52% said that the oncologist and urologist information was fairly helpful. 35% said Kidney Cancer Canada information was fairly helpful. And the family doctor's information was about 1/4 of the time was valuable. And that's understandable because most family doctors are not specialists like Dr. Kapoor and don't know everything under the sun about kidney cancer. And so this 35% concerned us as a board, and so we set out to do something about it. We wanted to get that figure up. We'll talk about that in a minute. This is barriers to treatment. Sorry, my glasses don't work close up. I bought new ones and I was vain, I didn't get them as bifocals, so now I'm going to suffer through blurs and little squirrels dancing on the screen. Can't see it too well, but I will remove them, how's that? And then side effects were a barrier, all the way down to the issue of not having access to treatment in the province. Maybe we'll look at it up there. It's actually bigger there, wow. In fact, I need an iPhone that's that big. So, I want to talk about Dr. Kolmsberger for a minute, just to annoy Dr. Kapoor. There we go. There we go. Just to do it again, in fact, Robbie and Dr. Kolmsberger did it. Dr. Kolmsberger was asked at ESMO, which is the European Society of Medical Oncologists, to review a survey that was done by the International Kidney Cancer Coalition. And this was a survey that had 1,983 respondents, 43 countries, 14 languages, and 30 patient groups around the world. And it took basically looking at the areas of clinical trials, patient knowledge and understanding, quality of life, and shared decision making. And Kidney Cancer Canada, so thank you to everybody in Canada, was the top respondent to this and responsible for 14% of the data. So I just want you to have a look at this, because when we talk about knowing what's going on with your care, knowing where you're going, this is important. 43% did not understand the subtype. 38% said they were not told the subtype, the diagnosis. And 11% still did not know their subtype at the time of the survey. 29% of patients reporting not being engaged in their treatment decisions at all. That's concerning to us. When it came to clinical trials, we said, were you asked to participate in a clinical trial? 70% of the respondents said they were not asked to participate in a clinical trial, and 89% of that 70 said it was fairly likely they would have participated if they were asked. That kind of reflects our numbers when we did our survey back in 2015. 45% said that their doctor did not discuss a clinical trial that might be open to them. So these are numbers, so we need to get that up, because really, as Dr. Ott said, that generally, when you go on a clinical trial, stop me if I'm going out of my bounds here, but generally, you are compared against the current standard of practice, right, Dr. Kapoor?
That's correct.
Okay? So if you're asked to go on a trial, you are going to at least get the standard of care. So think about that. You're not a guinea pig. And clinical trials are not end-of-life care. A lot of people think that, but they're not. They come across many opportunities. And so I would always ask every time I'm doing, is there a clinical trial open that I can go to? The other issue that was raised in the IKCC survey was psychosocial issues. 96% of patients are impacted by psychosocial issues. Most common, 60%, was disease-related anxiety, 50% fear of recurrence, 44% fear of dying, and 31% general anxiety. And I think probably that applies to caregivers and their families as well. And hands up those who've had any of those fears as they go through it. All right. Now, hands up those who discussed it with their doctor. Look at that. It kind of holds this out. 50% did not discuss this with their doctor. So we did a little bit of talk about this recently in a board retreat. And the clinician that came on actually was Dr. Kolmsberger. He said, we don't necessarily refer it through to a social worker, but if asked, we will. Is that the same here in Hamilton? So ask, sit down. And if you've got concerns, ask. Advocate for yourself. I think you should get a referral to someone. I went, boy, it helped me. I actually thought I was depressed. And I remember sitting in this meeting, bawling my eyes out because I was depressed and I was scared. And they listened for a while and said, actually, I think you're grieving. And because you've got this, and this, you've lost a body part, you think you've lost time, your body lost time, some mobility. And I went, yeah, I'm grieving. And walking out of that room, instead of crying tears of agony, tears of joy that I wasn't, in my opinion, having a real emotional breakdown and was I going to survive? So, you know, I think it's a good thing to talk about that. And guys, we don't like talking about it. I mean, I will tell you that, you laughed back there, but I will tell you now that we recently had, I'm not sharing anything out of school, we had a patient call, well, it was a caregiver call, lady called, about her husband, after he'd had his radical nephrectomy, had erectile dysfunction immediately afterwards. And this was really bugging him, and he was going through major anxiety, major depression. And I said, has he spoken to anyone about it? No. Does he know you're calling? No. And we kind of said, well, maybe we should have a chat with him and say, you know, do you want an erection again? Because if you do, you're going to have to talk to someone about it. You know? And that really, she was thankful, but it worked, right? Women, I mean, it made me put it into, one of the laughter about it.
It's because it was a patient from Quebec and I was doing the translation.
Oh, yeah. I was sitting in a quiet restaurant talking about erections in Barcelona. And, the table beside me, just the jaws dropped to the ground. And then all of a sudden the women started bursting out laughing. I don't know if that was me, but anyway. Talk about. So what do we do with the survey information? Well, one of the things we do is we look to trying to build engagement, trying to build advocacy to get us moving forward. One of the things we've done is build the Kidney Cancer Video Knowledge Library. This is a depository of hundreds of questions answered by doctors such as Dr. Kapoor, Dr. Ott, all across the country. And this really shows you where, across the world now, how people access this. Most in Canada, but since we opened it, the 25th of November last year, it's a number embedded in my brain. I can tell you now, it's had, I just like the fact I want you to see it again. 62,000 impressions. 62,000 impressions, and 27,000 come from Canada. So it's being used. People are seeking information, and we're thrilled about that. Honestly, it excites us amazingly. So what is the Video Knowledge Library? I'm praying that the audio works on this, otherwise you're going to get Steve and Andrew narrating a video, which is not good. Here we go.
If you have questions about kidney cancer, you can find hundreds of answers from leading clinicians in the Kidney Cancer Canada Video Knowledge Library. It's simple to access. Just click the link on the kidneycancercanada.ca homepage. Then select the appropriate area of treatment you seek for information. Here, you'll discover videos with questions and answers from leading kidney cancer experts. Choose the video you want to watch, and it will pop up on the screen. You can turn on closed captioning in the video here in the bottom right of the screen by choosing the English option. Another way to search, type your question in the search bar on our homepage, and a list of possible topics should lead you to your answer. If you need help or have a question not answered in the library, complete the form located at the bottom of every page in the video library, or select the form from the front page of the library, and we'll get back to you.
Very simple. There are lots of questions in there, such as what is cabozantinib, what is Cabomex, cabozantinib, what is sunitinib, what is sutent. You know, we tried to do them. We sat in Dr. Kapoor's house for a while. I won't tell you what he was up to when we were doing it, but we had a lot of fun. But it's a great resource. You please have a look at it. And if you have questions, let us know. An unintended consequence of this is that we now get more questions peer support questions from around the country. And since we opened it in French as well, we now see, which is the second highest incidence of kidney cancer in Canada, we now are getting questions that we're getting like 4 or 5 a day at least, and it's tremendous. It's a really good reaction. The other thing we've done is we've updated our website. And I won't go into great details about it now, but please go to it. Click on, you'll see on the front page there, in this area here, you'll see that there's where it says, let me see, the mouse work? No. Across the bottom, you see these, the blue box there, that's the video knowledge library. You can click on it. Order free resources, we'll send them to you right away. There's also new patients. And if you click on the clinical trials page there, you can do a search for any clinical trials. If you've had previous drug treatment, if you haven't had previous drug treatment, if there's a clinical trial in radiation, you can see it. You can type in Hamilton if you're in Hamilton, and it will give you a list of all the clinical trials there. And then you can print the page, take it to your clinician, your referring urologist or your GP, and see if you're suitable for going for that trial. And we'll have more on this next year, but it's a great way of doing it. Some of them will have exclusions, and some of them will have inclusions that you will need. But again, if you have questions, ask us, and we'll get back to you and let you know what's going on. It's a great resource. In fact, it's so good that actually now clinicians within the field are using it. We update it on a regular basis, and it probably is the most comprehensive list of trials across the country. I went quick. Thank you very much for listening. Any questions that you would like to ask before we move on? I know it's getting late. Okay, thank you very much.
That was fantastic. You gave a great summary of that, Kidney Cancer Canada. Great resource. I came to my clinic this afternoon and we saw 3 or 4 patients with metastatic kidney cancer that were not in Kidney Cancer Canada, but now they are.
Yeah.
That's good. So keep up that momentum. I want to introduce Dr. Slavin. Dr. Mercer Slavin is a colleague of mine from the Jervinski Cancer Center. He graduated from McGill Medical School. I wanted to train in internal medicine and medical oncology at Harvard. Nice, huh? So he's been practicing palliative care for 25 years in a variety of clinical care settings and has worked as a palliative care consultant at the Jervinski for 14 years. Her research interests include advanced care planning and medical cannabis. So, Marissa, thanks for coming to speak to us.
Thank you all for staying awake and staying for the last bit of the talk. We'll get the slides up and we'll get going. Perfect. Thank you. Yeah, so I'm a palliative care doctor. I work at the Cancer Center, and I'm going to talk to you a little bit about palliative care, very little bit. I'm used to going last. Palliative care usually does go last. And then we'll talk about cannabis. So in palliative care, one of the newer things that you may come across is that we're not talking about palliative care anymore. We're talking about a palliative approach to care. And palliative approach to care means that any doctor, not just a palliative specialist, can help with palliative needs. What are palliative needs? Well, palliative needs include attention to all the things like your biopsychosocial and spiritual needs for people who are living with life-threatening illnesses in their families. So a long time ago, people used to think that palliative care was end-of-life care. And more recently, we came to realize that it's not. It's about taking care of people while they're living with cancer, while they're getting active treatment, and helping them and their families in all sorts of ways. And really the goal of a palliative approach to care is to maximize your quality of life. Whatever you're going through, whatever your family member or loved one is going through, we would like to help to make sure that the quality of your life is the best that it can be. Because there's so many aspects to us as people, not just our kidneys, it really requires a whole team of experts to help patients and their families. And certainly the team can include doctors, both primary care doctors and specialists who could be oncologists or palliative care doctors. But a good interdisciplinary team also includes nurses, social workers, we heard a little bit about, chaplains or spiritual support, bereavement counselors, child life counselors, if you have children or grandchildren who are affected by the illness of a family member, nutritionists, and OT and PT. So really a good palliative care approach would involve any of these things that a patient or their family needs. The physician role in the palliative approach to care, because that's what I do all day, so I'll talk about that, is really to help patients and their families to access appropriate services. So that might be home care, but it might be to see an interventional pain doctor, it might be to see a radiation pain doctor. Certainly we look to provide pain and symptom management. So it's great if you're doing deep psychotherapy work to help deal with your illness, but if you're throwing up all over the place, it's not going to get very far. So we want to make sure that your pain is under control, that your nausea vomiting is under control, that your symptoms are managed so that you can get the most out of life, and so that you can go as far as you can also with your different treatment regimens. We certainly will help to facilitate serious illness conversations and advanced care planning. We don't push this on people. We take a meet you where you're at approach. If it's something that you do have questions or concerns about, we certainly have the time built in and the expertise to speak about these things. But if somebody's focus is on living as well as they can, and this is not really the area that they're interested in at the moment, a palliative approach to care would be to meet you where you're at with it. So what's new in symptom management? One of the big things the palliative care doctor would do is symptom management. And to be fair, there's not been a lot of research into symptom management. It's not highly supported by pharmaceutical industries or by governments, so there hasn't been a lot new. This is what's old in symptom management, so you may recognize this poppy flower. And poppy flowers are where we get opium from, and opium is where we get narcotics from. And in managing pain, narcotics have been the mainstay of pain management for these many, 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 many years. But there's a new plant on the horizon. It's not a new plant, it's been around for a long time as well. This is cannabis, if you don't recognize it. For the last 70 years or so, it's been out of favor in terms of managing medical symptoms. And then, as I'm sure many of you are aware, more recently, there is an increased interest in seeing, is this something that can help with symptoms? Opioids help a lot with pain, but they don't help everybody's pain all the time, and they do have side effects. Certainly we'll talk about other symptoms that cannabis may be helpful for, but again, there are other drugs for, but that don't do the whole package either. And I'm not saying that cannabis does. It's just nice to finally have something potentially new to help our patients manage their symptoms. So one of the things that we commonly hear these days is that marijuana is natural and so it must be better for me, and I just want to highly caution people against that fallacy. Many things that are natural are actually poisonous to us, so we wouldn't want to take those. Many of traditional chemotherapies come from natural agents. Digoxin, which is a heart medicine, comes from foxglove, and if you take too much of that, you'll die, so don't put it on your salad. So just because something is natural doesn't mean it's good for you or bad for you, right? It could be either one, and we have to sort of figure that out. So in the next little bit, really what I hope to talk about is a background and information on medical cannabis, because what I've found is that when I speak to people, there's quite a wide range of knowledge. There are definitely people out there who are quite the connoisseurs in medical cannabis, and other people don't know much about it at all. And if we're going to talk about it a little bit, I'll just sort of give you a baseline knowledge that you can build on. And then I'm going to review the efficacy of cannabis in 3 common symptoms and talk also about a clinical trial of cannabis. So what is cannabis or marijuana? It comes from the leaves, stems, and dried flower buds of the cannabis plant. There are 2 main species of cannabis plant that you might have heard, sativa and indica. But there are also now many, many hybrid species of plants. So there's sort of the 2 original and then lots of different combinations of them. And even in each species, they have different strains. So sort of the very first fallacy that we hear in people who are speaking about medical cannabis who don't know much about it is they're talking about it as if it's one thing. And to me, that would be like saying alcohol is one thing. And obviously, beer is not the same as wine, is not the same as vodka. And cannabis is not the same as cannabis, is not the same. There's all different kinds. And so if you think about it in that way, we really have a lot to learn and a lot we don't know. In a plant, in the cannabis plant, there are over 700 individual chemicals or proteins, at least 70 of which are active cannabinoids. The two major ones that we know about to date and that are found most predominantly are THC and CBD. But there are many minor ones, so it means they're present in a lot lower amounts. They're called terpenes. But just because they're in a lower amount doesn't mean that they're not active or important. It just means we know even less about them, and there's more to discover about what they may or may not do. There's different ways of taking medical cannabis. So inhale or vaporized. For medical cannabis, we would not recommend smoking. Oral or sublingual or buccal. Buccal is inside your cheek, sublingual is under your tongue. And this chart just sort of shows you it really is quite different. So we talked about different strains and different compositions. It's also a different drug or medicine depending how you take it in. So in one way, if you take it in, it could start to work in 5 minutes. Another way, if you take it as an edible or an oral oil, would take 60 minutes. And when you look at how fast it works and how long it lasts in your system, again, I'm not going to read you the whole chart, but you can see that it's quite a wide range of time frames and of bioavailability. So when we think about medical cannabis, what are the percentage THC, CBD, what type of plant it is, and then how is it being taken into our body? What about dosing? This is a really big question. As physicians, when we're trying to help our patients with most medicine, we know a dose. This is how much you should take. This is how often you should take it. In cannabis, it's a little bit more complicated. On the one hand, we're not using it to treat a cancer or an infection or something that we're going to measure and respond to. We're using it to treat a symptom. The person who has the symptom is the one who's going to know what the right dose is for them. So there's no standard one right dose. It's individual for each person. What we do recommend with dosing, and again with patients who I'm treating, I'll be very, very specific, but in general, we would recommend if you're cannabis naive, that you start at a very low dose and you go very slowly increasing it. The more THC is in the product, the more slow you should go in increasing the dose. Because THC is really what gives you the psychotropic effects, and that's where we see most of the side effects, and I'll talk about the side effects in a moment. And really what we're looking for when we look at what is the right dose of medical cannabis for an individual patient is what's the dose that they get symptom relief and they don't have any bad effects from it. And that's how you know what the dose is for that person. So it's actually quite similar to what we do with narcotics, is we start at a low standard dose and we increase until we see the benefit and not see side effects. It's good to know that in terms of medical cannabis, studies have shown that people do not develop a tolerance to the benefits. So that if you did try it and you found a dose that worked for you, it would continue to work for you if everything else stayed the same. Your body doesn't get used to it in that way. It's also important to know, and this is the last point, but it goes back to the go slow, is that more is not always better. You know, you say, well, why don't I just start with a bigger dose? Why do I have to start low and go slow? You start at a bigger dose, you can actually have bad effects. So for example, if you're taking it to help with anxiety, a small dose can help with the anxiety, a big dose can cause anxiety. In terms of really serious, significant adverse effects, they're pretty mild. So there have been no deaths reported from an overdose of cannabis. In terms of inhaling it, which would be the fastest way to get it into your system, so if you were going to see a really toxic effect, you'd expect it that way. You would have to smoke 800 typical joints, which have about 1 gram in each, to die. and you would die from carbon monoxide poisoning, not from cannabis. So this has never actually been done. In general, the side effects are within the range of what's tolerated for other medications. So what are the side effects? There's a wide range. Some that you would be maybe more familiar with include feeling intoxicated. That's why people are taking it for non-medical reasons might take it. Drowsiness, mental slowness and slow reaction time. Lung-related, related to smoking or vaporizing, it can cause cough. GI, gastric can cause increased appetite and weight gain. Sometimes that's actually a desired effect in cancer patients. Cancer hyperemesis syndrome, so I'll talk in a little bit about how cannabis is actually good for nausea and vomiting, except in the rare person where it actually causes nausea and vomiting. So that can happen as well. So one of the really big concerns that I hear from healthcare providers, from patients, and from family members about using medical cannabis is a concern that it's a gateway drug. So, you know, this is sort of the history that it's had as a more recreational drug, and if I start to use this, what's going to happen next? Am I going to be a druggie? In terms of your chance of becoming physically dependent on it, meaning if you stop taking it, you go through withdrawal, it's much, much less chance of that happening than with typical medications that we use like clonazepam or Ativan, lorazepam, certainly much less than with narcotics, cocaine, or even nicotine, which is quite addictive. Overall, there's a 9% lifetime addiction risk. 16% in people who start in their teens. So if you're not in your teens, your risk goes way down because the 9% is the average. The addiction does come on slowly. It's not like a sudden you take one puff and you're hooked. And the risk of new onset addiction is very, very low after age 25. So I don't see children at all in my practice, and even young adults. It's pretty uncommon at the cancer center. So I really try to comfort people and say, you know, I'm not worried if you're taking this medically that you're going to become addicted to it. This is a really important point. So I want to talk about medical cannabis over homegrown or dispensary. And, you know, there were for a long time many illegal cannabis stores. There are now 2 legal recreational cannabis stores. The recreational cannabis stores don't dispense medical cannabis. And I think it's really important to get your source somewhere where it's regulated by the government and you know what you're getting. There's a few reasons for that. So medical cannabis is subject to strict growing and labeling regulations. As I said, there's 700 chemicals in a cannabis plant. To get a licensed producer license from Health Canada, the growers have to know exactly what's in it. This was from a study done by the Toronto Globe and Mail, where they looked at Toronto dispensaries that were some of these illegal pot shops. And what they found was a large percentage of the drugs sold at these shops do not meet what they claim to have in them. So whether it was the THC content, whether it was the CBD content, I mean, it doesn't mean you might not get a nice placebo effect from what you buy, but you're not getting what you're paying for. And I have a real concern at the bottom of the slide for cancer patients in terms of their immunity, and this is a plant, if it's not grown and treated properly, it can be sprayed with all sorts of pesticides, but it can also have all sorts of infections, and cannabis plants have been known to have serious fungal infections that if people ingested it, it could cause problems. So I think we really need to be careful, especially for patients who have cancer, whose immune systems might not be as strong, to make sure that you're getting your cannabis somewhere safe. Okay, last slide on general information, and we'll talk about symptoms. Very, very important for everybody to know that whether it's medicinal or recreational cannabis, you're okay to travel with it anywhere in Canada, but you're not allowed to take it outside of Canada with you, even if it's medical, even if you have a prescription and you have the prescription with you, and even if you're traveling to somewhere else where it's legal. It's a federal offense, and they can arrest you for this. So please don't try and travel with it. Driving, we're learning more and more about the risks of impaired driving. How does cannabis compare to alcohol? How does it compare to narcotics? Certainly it does change reaction times. And we caution people with this. And the last really important piece of cautionary advice is around storage. If you have medicinal cannabis, please make sure that it's out of reach of children or animals. Children or animals, because they're smaller, can get quite sick from it, and it's really not fair to them. All right. Okay. Last thing. So everything there was about sort of plant-based cannabis. There are some synthetic cannabinoids that have been around for some time. One is called Sesamet, and it's a synthetic THC. The nice thing about it is that it's covered by ODB. It's a pill. Your doctor can write you a prescription. You can get it filled at any pharmacy. It's more of a long-acting pill, so you take it 2 or 3 times a day. Overall, it's probably not as effective as the plant, but it's not ineffective either. And since it's covered, I actually often start this with my patients first, so that they can not have to pay as much. Medical cannabis is not covered. The other synthetic cannabis is called Sativex or Nabiximol. It's a spray. It's a combination of THC and CBD spray, and it is approved and licensed in Canada for palliative cancer pain, but it's not covered by the Ontario Direct Benefit Plan. Some private insurance plans do cover it. It typically costs about $300 a month, which is a bit more than the average cost of a medicinal cannabis prescription. All right, I'm going to go really quickly through this. So in terms of effectiveness for cancer symptoms, the National Academy of Sciences and Engineering of Medicine has a consensus guideline that came out about 2 years ago based on extensive literature review, and they have recommendations on cannabis, cancer, everything. I've just picked 3 to sort of talk to you about today. Cancer Care Ontario is working with McMaster Program in Evidence-Based Medicine. I'm on the expert panel consulting, coming up with our own specific Ontario guidelines around cannabis for cancer. And even we're using the National Academy of Science and Engineering as a baseline and sort of going from there. They did a really good job. So what did they find? For chemotherapy-induced nausea and vomiting, the conclusion was definitive that there is evidence that oral cannabinoids are effective antiemetics for the treatment of chemotherapy-induced nausea and vomiting. So there have been plenty of studies on, well-done studies. It's clear that this is a good effect for cannabis. In terms of anorexia, losing weight loss and loss of appetite, currently there's insufficient evidence that would either support or refute the conclusion that cannabinoids are an effective treatment for cancer-associated anorexia, cachexia syndrome, and for anorexia nervosa. So it means we don't know. It might work, it might not, there's not enough evidence. Most of the studies that have been done were in HIV patients, not cancer patients, different mechanism of disease and illness, so it's hard to know how that would translate. And last, in the area that I'm really interested in my research is in cannabis for cancer pain management. So at the top of the slide it just says pain. It doesn't say cancer pain. And there's a problem here. There is substantial evidence that cannabis is an effective treatment for chronic pain in adults. This is from the same National Academy. However, they did not even do a section in this report on cancer pain because there are so few specific studies for them to review. So that tells you something. And certainly it spoke to me because for 25 years I've been seeing cancer patients who have pain, and it's hard to believe that this hasn't really been studied. In fact, there are only 5 studies of cancer patients' pains and cannabis. There are some studies that include cancer patients in with other patients. So for example, this review and meta-analysis had 28 studies and 2,000 patients, looked at all different types of cannabinoids, but only 3 of the 28 studies included cancer patients, and they weren't specific to cancer patients, they just had some cancer patients in them, so not really very helpful. I think in the interest of time, I actually have put up slides for 4 of the 5 studies that exist. If people want to know more information about these studies, we can come back to them afterwards. But I guess the takeaway from the 4 studies that were done is that there does seem to be a signal that cannabis helps with cancer pain. We don't have enough evidence for sure. I mean, 4 studies, and 2 of them were done in 1975. A little bit outdated. The other 2 are more recent. They both showed somewhat positive results, looking at THC and CBD compared to placebo. They tended to be in patients who were quite ill, terminal cancer patients, and a lot of those patients had already been on very high doses of opioids, had very advanced cancer, very advanced pain, and even in those situations, it did seem to help. So all of this was sort of enough for me to decide, I really do think we need to gather more evidence of this. It certainly was enough to interest a sponsor, which is Aurora. We have another study coming up soon that's going to be sponsored by another big company, which is Canopy, so trying to keep it all fair and even in that way. And I had help with the wonderful colleagues up at the Cancer Center, the Ontario College of Oncology Research Group. So this is the current study that we're doing at the Cancer Center on cannabis for cancer pain. It is the only actively enrolling cannabis study in Canada for cancer pain. It's Health Canada approved. There are some other Health Canada approved studies, but they're not enrolling patients yet. So we're really pleased and proud to be the first study that's up and running that's looking at this. And really what we're looking for is to see, does it help cancer patients who are having pain to manage their pain better? We're not looking at terminal patients, as the other studies have done, really patients anywhere along the trajectory of their illness if they're having pain. And it's not a placebo study. So I don't have free samples tonight. That would not be legal. But if you go on the study, if you were eligible, you would get free cannabis. So there's some hope yet for free cannabis. In addition to improving the pain control, we're looking at quality of life, we're looking at side effects, compliance, and pain scores. The study is open to men and women with a whole variety of cancers. GU, genitourinary cancer, so kidney cancer is in there, would be eligible. Age ranges are 25 to 70. We've had quite a fair bit of complaint from people over 70, so I think our next study will bump the age up a little bit. The Edmonton Symptom Assessment Pain Score greater than 2, so this is a 0 to 10 scale, where 10 is your worst pain ever, 0 is no pain, so we're really not necessarily looking for people who are having the worst pain ever, even a little bit of pain. You would have to be taking some pain medicine for the pain, though, at the time of entry into the study, because one of the ways we would know that the cannabis was helping is over the course of being on the cannabis, you needed less pain medicine. If you came in on no pain medicine, you couldn't need less than none, so we wouldn't know it worked. We are not taking people who are currently on cannabis, but if you're using cannabis and are willing to stop taking it for 30 days, then you could be on the study and you can get free cannabis on the study. And of course, you contribute to medical knowledge and medical science and help people who come after you to also manage their symptoms better. We're mindful of cancer patients who are in the middle of changing their treatment plan at the same time as starting on our study. So you can be on a clinical trial and be on this. You just can't be changing your other treatment at the same time. You have to be able to come back and forth to the Cancer Center on a regular basis. And the bottom thing is about your morphine equivalent, which is to say you have to be on some narcotic. It doesn't have to be a high dose. In fact, if you were on a high dose, you'd be excluded. But if you are interested in the study, we do the dose calculation and tell you if you were within the eligible range. And I'm going to stop there.
That was excellent, great talk, and it's very I have a quick question about, a lot of patients are taking cannabis for treatment of their cancer. So we do have some patients that say, I want to take this cannabis and it's helping my cancer get better. I've put on the internet that some fellow took it out in some other place and the cancer got better on cannabis.
Right.
What are your thoughts on that?
Yeah, so I get asked that question a lot as well. Yeah, the
There you go,
answer,
you were
right?
I see that. I didn't set that up.
Yeah, no, I also get asked that question a lot. There is no evidence to date that supports that cannabis can cure or treat cancer in human beings. So there are some studies looking at it in petri dishes with cancer cells, seems to work, and even some studies in mice. One of the most common studies you'll see is in people with brain tumors, and they're like, oh, it worked in this person with brain tumor. No, they took the cells out of that person's brain, put it in a petri dish, fed it cannabis, and it worked. It's not the same as saying it works in a person. The Academy of Science and Medicine, in their report, reviews all the evidence in detail. Again, says there's no evidence to support that it cures cancer at this time. And I just have the Rick Simpson oil up there because that's one of the most common ones. It's a very high THC oil. And we've seen people have very significant bad side effects from this, both acute delirium, hallucinations, going into the emergency room. We think they have brain metastases, they're so bad, as well as long-term depression from it. So I really urge people to be very careful about that.
That's great, thank you. Any other questions, Ranjana?
Thank you for your talk. Is there any concern about drug interactions? So Dr. Ott gave a talk about all the current plans of therapy. Is it well known if cannabis has any interactions that people should be considering in terms of adverse reactions or affecting the efficacy of their cancer treatment drugs?
Yeah, no, so that's a good question. I'm going to break it down sort of into two parts. One is, are there any drug-drug interactions? And the other is it going to impact the treatment I'm getting for my cancer? In terms of possible drug-drug interactions, cannabis is metabolized in the liver in very much the same way that many of our prescription drugs are. So like any of those, it goes through the liver, it's processed in line with all the others. The question, and this is a really important question that's been asked, is does it interfere with my cancer treatment? To date, there's been very few studies looking at that. The biggest and best study was done in breast cancer patients looking at hormone therapy and did not find that it impacted their treatment at all. One of our next studies is going to be looking at that as another element as well to make sure that we're not, because we don't want to cure the symptom and have the patient die of the disease, right? So it's important to look at. It doesn't seem physiologically that it would impact it, but can I tell you 100% the research is there to say, nope, you're perfectly safe? I can't tell you that.
Fantastic, thank you so much. So we're right on time, 9:03. Thanks everybody for coming tonight, and we're still here to answer any questions. And have a great evening. Thanks for coming.